Three, two, one. Hi, this is Josh, and this is the fourth episode of the Status Dramaticus podcast. So, as promised, I have a guest with me. I have Cody. Cody is a medic since 2012. He's been working in multiple systems. Today, he has a home.
We'll call it that.
Yeah, we'll call it that. But one thing I do want to say is, Cody, I've worked with you before. I think you're a very solid medic. Like, you are not afraid to go through the whole treatment modality for anything. And I think a lot of times that's an awesome thing to be, like, especially in situations like where you need mag sulfate, that type of stuff.
Yeah, definitely. We give protocols for a reason.
Yeah,
Use them.
that's right.
Yeah, we're giving drugs. Use them. We're here to treat people. That's my mindset.
That's what I always remembered about you. You had no fear about, treating to the most of your ability there. And well, I guess that's a good segue too, because there was a letter from MIMS that came out, right?
Yes.
Okay.
Came out on the 6th of April.
Okay. And this was in reference to Terbutaline. So a lot of you providers out there know that Terbutaline went away for a little while. But now it looks like it's made a resurface, and maybe this has something to do with the aerosolization during this COVID thing with albuterol treatments. So just the quick rundown for that. It's a grouping mild, moderate, and severe distress. The mild distress, they're just talking about a meter dose inhaler, 4 puffs, repeat in 5 puffs, max dose 8 puffs. With the Terbutaline in itself, it makes an appearance in the moderate distress category. If it's 12 years or younger, you're not doing Terbutaline. You're still going to remain with the IM epi. With 12 years and older, you can do Terbutaline, 0.25 milligrams IM. Is it IM?
Yeah, it's IM.
I just want to make sure.
If need be, you redose in 15 minutes.
Okay, good.
Total 0.5.
All right, so your max dose is 0.5 milligrams, and in severe situations, it's epi or Terbutaline. And then there's always the precaution that if they have a known cardiac history, that maybe you would want to deter from the epi.
Right, correct. And we get that at severe. You're giving a nebulizer still in. Throughout this whole letter, MIMS references the respiratory distress protocols. So it's not saying totally replace protocols, but definitely heavily consider it this way.
I think it's a good idea. I mean, we were talking before this podcast about there's a lot of people out there that missed Terbutaline. I think you were one of them.
Definitely one of them. That was an everyday thing for me, man.
It's a nice treatment option when you have it available to you. But so that's our update. What the topic that we really wanted to get into is something that you care a lot about, Cody. It's the humanizing the call, I think is the way that you put it.
Yeah, that's about the best way I could come up with describing. Pretty much came through this, being my own maturing as a provider and just seeing how people interact with others and how we treat our patients in the field and to an extent, I guess, in the hospital. I can't really speak too much for that, but I kind of get the feeling it's kind of the same in both places.
Yeah, I think there's a mix. There's some people that just aren't, well versed in communication with other people. I mean, that's no matter what job you're in.
Yeah.
And then there's the other thing, like sometimes you've been doing the job a while, you get a little complacent, or sometimes, God forbid, you get a little crusty.
Yeah, that's a good word.
But there is something to be said at maintaining some kind of demeanor for your patients. So what I did want to ask you is, what was it that got you so interested in this topic?
Like I said, I think just me growing as a person and changing my perspective on life, and then, doing things that, looking back now, I don't agree with how I treated somebody, maybe as a patient, or just trying to break maybe some stereotypes. Because from day one as a provider, I've always been breaking stereotypes of maybe how I treat people or, equipment that I may choose versus others. And I think this kind of developed out of that mindset where I think sometimes we don't necessarily treat people the best in this field, and we should treat people a lot better.
Yeah, I agree with you. I think it's tough in an emergency sometimes because there's tensions running high. But also the importance of like remaining calm and trying to get people on the same page as you, because we're going to talk about a lot of stuff. Like the common person has no clue what we're talking about when we say Terbutaline.
No, not or a 12 lead.
Or a 12 lead. But, I mean, for that matter, even EKG. Sometimes they're like, what does that do?
Right.
But that's a tough call sometimes too, because sometimes I think how literate as a culture should we be in healthcare matters as a society?
I think that's a really good debate for a whole other day. Though, really, just,
Yeah.
like most people come out of high school with like a semester of health knowledge, and it's all based on drug abuse and STDs.
Yep, that's
And
right.
That's it. And we've kind of proven that drug abuse part doesn't really work.
Yep, absolute abstinence and complete prevention,
You
right?
go ask any like dispatcher like what they're getting calls for 911 for. It's definitely not 911 calls usually. It's nothing important.
Right.
It's just the basic mindset that we don't teach people.
Yeah, and I think that's tough. So, what are some ways that you would go about or emphasizing how to talk with patients?
So I'm going to preface the rest of this. So like this is probably going to be somewhat of a controversial little bit of issue because it's different than what I think EMS is used to. And again, probably emergency medicine in general, we're not necessarily used to this.
Yeah.
There's some people who do it well. I can think of mostly they're doctors and a couple of medics who are just super compassionate, empathetic, and sympathetic to people, but they're also good at what they do.
Mm-hmm.
And then there's some people who are just phenomenal with medicine. They just treat people horribly. So again, like I think that's kind of like where we're at mostly is like maybe we're not treating people horrible, we're just not treating them as good. So basically I think the big things I was looking at for was compassion, empathy, and sympathy. Just different ways of thinking about it.
Okay.
One of the things I got some notes here was often we go to like calls on the ambulance and we have like this weird authority attitude. Like we go to these overdoses or these assaults, and it's like, we want to be stern to like, make sure, that we're going to be taken seriously. But at some point we start getting confused for cops or any kind of law enforcement in the jurisdictions. And, we really aren't an authority. We're there to be, what another medic told me once, we're Switzerland, we're there to mitigate an issue, not create more issues. And often we have this authority attitude where we're creating more issues and we're talking down to people. And then if we have to transport somebody like that and you've already talked down to them, they're not going to trust you.
No, that's
patient trust is a huge thing for better outcomes.
That is a very good point. And I've thought about this in the past about the basic or stereotyped medic attitude.
Oh, yeah.
And sometimes I think it develops out of necessity. Like you have to be confident because it's like you and your partner. And if you're the paramedic, you got to be like the top dog on scene, and you have to be pretty deliberate in what you decide. Otherwise, if you're wishy-washy, people aren't going to listen to what you say.
And I think that's accurate, like 100% accurate. Like, you got to be the top dog, but I think a lot of times it's taken too far where like you become such a top dog, you're like barking at people, and it's like, whoa, what are you doing? Like,
right.
You can have a saying what the fire service calls a command presence without talking down to people, like leading through your actions through calmness, assertiveness, but calm, and still just talking to people like they're people. That's what, again, like a lot of this comes down to.
Right.
Just talking to people like they're people, not a number.
Right. Yeah, and I think it's even more important because there's a lot of people that have access to healthcare, but you're not going to get through to these people if they have a bad taste in their mouth after this interaction.
Oh, yeah.
That comes from the nursing side, EMS side, all of it. So it's just interesting how it's a very hard situation. So let's say someone's having an MI.
Okay.
How would you go about, or what are some examples of how you would walk someone through this?
I think a lot of it off the get-go is generally anybody who is in EMS has a first due area. Generally anybody in the ER has a general patient population. If you're in some inner city, you know that maybe the general patient population might not be as intellectual, or it might be they just don't know like about how healthcare works. Whereas if you go to a place that's a lot of nursing homes or has a little bit higher intellectual population, they might be able to grasp these higher terms. So saying things like a 12 we're going to do a 12 lead. You say that somebody who has no clue what they're talking about, you might freak them out. But I think most of your population is going to know what an EKG is at this point. And if they don't, you can even take it more basic level and say, like, well, what we're going to do is put these stickers on you, and it's going to take, the classic 12 pictures of your heart.
Mm-hmm.
But when you say that somebody who has a little more education on them, that might actually be offensive.
Right.
And some people really get offended by that. If somebody gets offensive, they get angry. If you're having a heart attack, that's going to cause more stress.
Right.
Or if you're trying to tell them we're going to do this 12 lead on you, and we're going to look for this ST elevated MI, they're like, what is that? That's what's that? I'm so confused. I'm lost. Or you're gonna lose them and not know. They're not gonna know what you're talking about.
Right.
So you might lose their trust even on that level.
Mm. I'm definitely guilty of saying 12 lead. I'm definitely guilty of saying EKG. But then a lot of times the patient will correct me and be like, well, they'll kind of bring me back down to earth with it.
Yeah.
They'll just say, oh, what are you talking about? What are you doing? And I always say, I'm taking a picture of your heart.
Yeah, I think that's a good way to go. I think if you go EKG, it's kind of right in the middle, and then you can kind of let them figure it out. Or they can kind of say, all right, I don't know what you're talking about. I'm like, all right, I need to get a step further. Or all right, I kind of insulted them.
But even honestly, even saying taking a picture of your heart, irks me in the back of my mind because I'm like, that's not really
It's not what it does, but
electrically, and then they're like, what?
Yeah. And I think that's the odd thing is people get back to the top dog mentality. We want to be the top dog at what we're doing with our knowledge to the point we forget we have to explain things at a lower level than what we're used to. We conversation before this, we were talking a little bit higher level of knowledge that if maybe even somebody who's not to pick on the EMTs, like an EMT, they might not get it.
Right.
We're using these bigger terms that you and I get that are accurate, but then somebody who doesn't have our knowledge base, they don't understand it. And so maybe this humanizing job even goes to that level is where you got to know who you're working with. I mean, my job, I work with a lot of, volunteer firemen, paid firemen who don't necessarily understand what my job totally is. They think I just load people in the ambulance and go. I was like, no, I'm not quite a doctor, not quite a nurse, but I can do some cool things,
Right.
Right. And to try to explain to them, here's what I need you to do to help me,
Yeah, and that's another testament too, is in our field, there's a good chunk of us that are constantly trying to learn more, trying to get better, trying to do more,
Right.
trying to be capable of doing more, and we're always pushing for more things, more knowledge, more skills, that type of deal. But it's a recognition that not everyone in the field is like that.
Right. And, part of, I think, this concept of humanizing your job is not just knowing your patients, but knowing who you're going to work with. Because you're working with the same people over and over again. You keep having this top dog attitude, you're just total authoritarian. You're not necessarily a team player. You're just a boss and not a leader. People eventually start looking down on that, like, wow, we don't want to deal with this guy, or they're going to be quick to do the bare minimum to help you and boogie out of the scene.
It's just like you've already lost your audience
Right.
with the people you work with, and then if you continue that, you're going to lose your audience with the people you treat.
And people start memorizing when certain people work. People know our shift.
That's true.
Patients too.
and really, and even when I was in EMS, your partner could make or break your shift.
Oh yeah.
How enjoyable your shift could be.
I've had some really miserable paramedics that I want to turn my paramedic card in from them, and I've been blessed recently, the past couple years, having some really great partners. I have a really awesome partner now, so it's great.
And the hospital's a little bit different, but it's still the people you're working around. My job is better because of the people I work with in the ER.
Oh, I agree. Even when I come to the field, if I hear certain doctors on the radio, I'm like, oh, we're going to have one of these days. There's how we're going to be. Because even some doctors don't necessarily know what a paramedic does,
Yeah.
And,
that's a good point. That's a very good point.
And I think a lot of paramedics feel like we get talked down to sometimes because certain doctors don't necessarily know what we do, and maybe they don't have the time to figure out what we do, or they just don't care. And I feel like if we have that mindset, then definitely, your general firefighter or your CNA or whoever else is below a paramedic, they probably have the same mentality about us.
And actually, that was
because a lot of us don't care about other jobs.
What you're saying is one of the reasons I started constructing a list for why I wanted to do this podcast. Because what always bothered me, and to this day, when I was operating as a paramedic, is when someone would just call me an EMT or a transporter.
Yeah.
I don't know why it always irked me. so much. But
Sometimes you could definitely use the ambulance driver to your abilities.
yeah, sometimes you can use it. You can pass off, seemingly pass off some that you didn't know something.
Right.
But the other side of it too is like I worked for that, like, and I'm
Yeah.
trying to be better at it. I would like you to acknowledge, and now I've kind of grown out of that, even with the
I
nursing
think
side.
that's a growth. I think we all go through that. And it's like, all right, I was like definitely flaunt. I'm the paramedic card. I've earned it. And it's like,
Right.
all right, time to be a little more humble about it all now.
It was hard in the beginning
Oh,
because
yeah.
I had to, work hard to pass all the tests,
And you should be
everything.
proud of all that.
Yeah,
But
absolutely.
eventually, I think we all get to a point where we start losing pride and we start becoming just arrogant.
Right.
And humility speaks volumes for people.
But I think that's the arrogance is easy to spiral out of control if it goes unchecked. That's why you need a good partner. I think
Yeah.
they can set you back down. And then also like this self-awareness, but
I think you need
that's
to fail a couple of times.
yeah,
Too. Like
failure.
you can't learn if you don't fail.
I agree
And
with
you also
that.
have to be open to learning, though.
Hmm.
That's something I've preached to Cody and a few paramedic students in the past is how are you going to learn if you don't let yourself fail?
Right.
'Cause you're not learning if you're just always doing good.
And I think that's
And
just a generally tough thing with anyone.
Humans.
Yeah, with humans.
We don't like failure.
And we don't like feedback all the
No,
time
we don't
either.
like feedback. It's rough sometimes.
But what I will say about EMS is and just nursing too, or any medical job, there's so many different ways to do things. I always did really appreciate a preceptor that was always able to say, that's your way to do it. There's nothing wrong with doing it that way. Good for you.
I think that's a good point to bring up. I didn't even really think about for this, but a lot of people don't want to be preceptors in EMS, so they don't want the responsibility, whatever that is really is.
Hmm.
But a good preceptor can really make or break somebody's career from the get-go. And if you have a preceptor who's like, this is my way, do it my way, and like doesn't let you learn,
Right.
or it doesn't teach you good habits of like talking to people like they're people, treating people like maybe we're not going to yell at the guy we just Narcaned.
Right.
Maybe we're not going to necessarily go fist to fist with a schizophrenic who's having an episode. Like, teaching you alternative ways of dealing with situations that might actually be better. You're going to start learning bad habits otherwise.
Right.
And somebody who can foster you will make you better in the long run.
No, I agree with that. It's how do you emulate that behavior and how do you pass that on to the next person?
I think that's a hard question. I think a lot because of maturity. Like, sometimes it's hard. It's like you start realizing, all right, you're getting called. Like my biggest thing, I was being called like arrogant, or like that was the biggest thing. Like, it's like, all right, I'm not being arrogant. I don't want to be arrogant anymore. But I was told I was being condescending to EMTs. That was like, oh my god. Actually, my girlfriend said that.
Oof.
Before we were dating. We were just occasional partners on a part-time job. She goes, "You're really condescending sometimes." I was like, "Wow, that hurts. That's condescending." I'm like, "Wait a minute." She's being condescending because I'm condescending. It's like this whole
It's a vicious cycle.
It's this weird cycle. It's like, wow, she's not wrong. Like, if she's telling me this, who else am I doing it to? And it's like that's where like my mentality shift changed. Was just that statement.
But you were in that moment. You were receptive to feedback.
Not at first.
Okay.
At first, I was like, I'm not being condescending. I'm the paramedic, man. I earn these letters, And
Right.
it's like,
Oh, there you go.
All right. I'm a little arrogant.
It's the pride with the
Yeah.
the empathy being at heads with each other.
Yeah, I mean, like I said, I think a lot of it it's just maturity and like knowing when to say, "All right, you're right, I'm wrong."
Yeah.
And I think that also comes through like life experiences too.
Well, when you said that, I can think back to preceptor paramedics I had as an EMT or just riding with them, and actually my experience were really good with those guys.
Right.
So maybe that actually helped
I could think back
go
to
further.
a lot of my better preceptors. I have good and bad. I think we all have good and bad preceptors. I mean,
Right.
And a lot of people like want to look and say the bad ones are ones they remember the most. But if you can like take what your good preceptors taught you, they're good preceptors in your mind for a reason. Whether it's the care or just the way they treated people,
Mm-hmm.
you can use one of them to be the foundation of the provider you want to be.
Right.
Yeah.
Take different elements from people you admire.
Right. It's like there's a lot of good. Like I said, there's a lot of good paramedics out there who I think who lack a lot. In the compassion part, but then there's some who are super compassionate, but they kind of lost track of the patient care aspect. And then it's like, is there a middle ground? And like, I think there's a hard middle ground. There's only so many in that middle ground.
Yeah.
I can think of like 5 at the top of my hand right now.
It's challenging because when I see a medic or I see a nurse that lacks any sort of compassion, I don't want to judge them in any critical component because I don't know what they've been through. But that's something I think about all the time. What have these people seen?
Yeah, and I think it's hard not to pass judgment.
Yeah, I agree.
Like, but it's human nature. We just want to judge.
Yeah, and I mean, judgments are how you make decisions. Like, if you
Right.
just nonchalantly went through life and tried not to judge anything, you're not going to get anywhere.
How often have you heard the term, I made a judgment call?
That's right.
I made a judgment call. All right.
I made a judgment
And
call, and
that's like
now
the
I'm here,
validation for everything.
either in jail or something good happened.
Or in the ER, tied down, right?
Right.
Or being talked about on a podcast.
Oh, that's right. That's right. All these stories. And I've had a lot of great nursing preceptors too that they were still very compassionate. They still were, and I think that actually made them better patient advocates. If they saw something not right, they were more likely to speak up.
I think advocacy is something where at least like places in like medicine where emergency medicine as a whole has kind of like been way behind them. I think we're catching up to that kind of well these days. Like we have different programs to help look out for people who are at-risk population. So maybe some of our advocacy is by force, but I think we're catching up to it a little bit. We're slow, but I think we're kind of trying to get there.
Well, it's a little cockiness as well, once you get it a little bit more comfortable in your job.
Yeah.
But maybe it's not even, it's more like comfort and competency.
Right. Sometimes it is hard to say, speak up, it's like, I don't think this is right.
Yeah.
Even though it's like, all right, this person's totally not getting either the care they needed here with me or at home or something, but it becomes sometimes the so status quo, you're scared to stand up to that.
Right. And I think this is also a portion of where a good partner comes in.
Yeah.
Because kind of like your wife was, or was it your girlfriend?
Yeah.
Was doing it to you then, like kind of keep you in check, keep you honest. It's just something that you need to accept to allow yourself to accept feedback too.
Totally agree.
Yeah.
So I think another like avenue which I was thinking about with this whole humanizing thing is like certain specific populations we don't necessarily treat the best.
Okay.
And some of this is out again like recent experiences of mine or talking to other providers. I talk to providers from multiple jurisdictions all the time. I have a lot of friends in where I've got around a little bit. Man, I probably shouldn't be so proud of that. Like the biggest one I think we probably mistreat and don't treat fairly enough that we should probably our psych patient population.
Oh, that's a
hard one. This could be a whole other topic.
Psych is I'm actively looking for people to talk more about psych because it is such a sensitive and a difficult topic.
Yeah, and I don't think I'm probably not the expert talk on this by any means, but I just don't think necessarily we are treating psych patients the best in medicine in general.
I agree with you, and a thing that comes up all the time from the ER perspective with nursing is the boarding in the ER while they're awaiting placement.
And I imagine maybe this isn't kind of one of those judgment things, but I can imagine the mindset is like, I'm an emergency nurse. This is not what I'm supposed to be doing.
Yeah, and I think that happens, but I do think that a lot of people I work with are compassionate about it, but I think the difficulty is what is the nurse's ill-defined role with a psych patient? Because most of the progress made with that psychiatric patient doesn't necessarily come from the nurse. It's going to come from the counselors, the behavioral health therapy, the psychiatrists, that type of deal. And then awaiting placement, because a lot of these facilities, they don't have a ton of beds.
Yeah, no, they're stacked. I mean, we have like one we go to occasionally that we take patients to in the ER. You're familiar with, I'm sure, and they're pretty busy.
Yeah,
people get stuck in these like kind of like middle ground places,
Yeah,
it's like purgatory.
even
That's
with
what
the
it is.
COVID stuff, you're still getting psychiatric patients. I mean, because it's a stressful time.
I feel personally like there's been a lot more psychiatric cases lately.
Really?
I feel like people have been a little bit like stir crazy, or people aren't able to get their access to some of their care. Maybe it just seems like a lot of the stuff we've been dealing with has been like psychiatric in nature and roots. That's where the roots are, I should say, I guess.
And I don't know the numbers, but I feel that,
Yeah.
It just seems that way.
it could also be just perception that like call volume for us has dropped off, and that call volume has it.
Right. Or just whatever you're getting on your shift.
Right.
I just happen to get
All these
6 psychiatric patients.
Meanwhile, another shift's getting all the COVID patients.
That's right. No, it makes sense. But the overlying problem with mental health is like everyone in some aspect, especially in an emergency situation, there is a mental health component to it.
Oh yeah. Whether it's the patient or your own, right? Eventually you get to worry about your own mental health.
Yeah, I that's another thought I have about our jobs.
Yeah. And I think go back to like just the actual psych patients. One of the things I think we fail them on is, at least at EMS, is I think we treat most of our psych patients kind of inhumane.
Okay.
Especially like, we look at them like, all right, maybe they're not a true clinical emergency. Because EMS is not necessarily treating us like best in psych. So we're not looking for all these psychiatric things. So we're not thinking, all right, we need to be paying attention for these acute changes in them. Or when we get them, they're combative a lot of times. So what do we want to do, a lot of people? Because we have this authority mentality, fight back. Is that really what's best for the patient? Is that even humane?
Right.
So, like I said, a lot of people like have this like ability or this mental thing where they just want to fight people back. It's like you're trying to fight somebody who's seeing things that you're not even seeing sometimes. They're not even playing on the same ball field. Is that humane?
Or even an emotional lability, like that they have no control over.
Correct. Like these people, like a lot of times don't have control over it to the point, like maybe they have a recent diagnosis with something and they can't get the access because the healthcare system is so overloaded. So they try to kill themselves by whatever means, and now they're having a psychiatric breakdown. So now they're fighting you. And maybe yes, they are under the influence of something. So now you're thinking potentially, all right, are they fighting me because they're just a jerk? Or are they fighting because they're actually having a breakdown? It's probably the breakdown. But what do you have to lose for treating them as having a breakdown and treating them as a psych patient versus just a jerk who doesn't want your help?
No, that's a good point. Well, someone called 911 to begin with, and a lot of times it is that patient.
I preach this to my partner, and I think he's a little newer, so I guess I have a little more leeway. But I'd rather people.
At 8 years, that's a good chunk of time there.
Yeah, that's a little bit compared to some people who are like they're like 45.
Well, we should clarify 8 years as a paramedic, even longer.
Yeah, longer than that. Now we're splitting hairs.
There we go.
But I think it's almost better to just, if you kind of assume somebody is kind of like a true psychiatric episode that's rooted in psych, you're probably not going to miss them having a psych episode. If you think somebody who's having a psychiatric episode is rooted in just being a jerk or being drunk or something like that, and you just treat them like that, you're going to miss psychiatric patients. And again, the psych patients are often, so we know that's like documented. And then what happens is, we get these people who are just super, super combative, and we tie them down, and we don't do anything else. And then what happens? We have excited delirium protocols on how to restrain people chemically.
Which was a cool thing that did happen, and that was a couple years ago now.
It's really came to light probably nationally within the past 5 years. I mean, 5 years ago, we were slamming 5 and 5 Haldol Versed. Now it's like, hold off on Haldol, baby. And try to give some Versed, then maybe some ketamine or Ativan, whatever your jurisdiction's allowing. And, there's still places that want you to physically restrain somebody, but, not chemically restrain them. So if somebody physically restrains somebody, they're still going to be writhing and fighting a lot most of the time. And they're at risk for danger themselves, And if our goal is to be patient advocates and treat people like we're going to be, like they're humans, like we should be treating them, we should be sedating them. And this is an opinion of mine, but it's really inhumane to watch somebody just writhe around, try to break out of restraints, who is having a psychiatric episode.
I think you hit something pretty significant. It's treatment. You are giving a treatment. Restraints is the least. I can't tell you how many times I've seen that happen, and I never feel good about it.
I don't personally like physical restraints because it is just inhumane. I feel like a lot of times, especially if you're not going to sedate with them.
I feel a little bit of my soul dies every time I have to participate in it.
Yeah, I mean, I think there is sometimes a necessary to that in the acute moment. But then if you can progress to the chemical part where it's a little safer, maybe go with like one of your choice of benzo first, and then maybe if that doesn't work, go with the ketamine or something, whatever you have again,
I like thinking about that too, and this is just another opinion I have, is when you have some psychiatric patients coming into the ER, I think sometimes they need that medication sooner as opposed to later.
Yeah, I think that's another. I think EMS, again, we fail at because some jurisdictions especially don't want people pushing drugs. they give you these drugs, they don't want you using them.
Yeah.
And that's a failure of the system, which creates a perpetual failure of bad medicine.
That's a tough one too, because then you have some of these jurisdictions out there that are struggling. So this is the crazy part about healthcare, and I think everyone's seeing with this pandemic is everything's intertwined.
Oh yeah.
If the health system's messed up in some way, then it's going to affect the economy, it's going to affect social order, it's going to affect everything.
Oh yeah. I don't disagree at all. I mean, like I said, I'm probably a little bit more liberal. Like I have certain patients who I've seen multiple times who I know when they're about to become combative.
Hmm.
I know that, like what they can do to themselves and what they can do to others. So it's like, hey man, are you feeling this way? And we got a long ride to the hospital. Do you just want to be relaxed and maybe go to sleep for a little bit? We won't even do any needles. We can just, smell this real quick and, boom, 5 intranasally, and the big guy's not fighting me or trying to kill himself in the back of my ambulance. And everybody's safer.
Yeah,
I mean,
that's
the sedation,
great.
I think traditionally sedation has been thought of as a provider safety measure, not necessarily
Oh, that's a thought.
as a treatment measure. As we're getting these drugs, like again, like I think ketamine's a big one that we're looking at now is just because we can use it for pain, we can use it for sedation, we can use it for, RSI, and there's places that have RSI, that some of these drugs do have multiple different things, and it's not just about safety, it is truly about treatment. And, we in EMS we want this recognition. We want to be recognized as actual providers or clinicians, what we're trying to use. And you see the wording from the state of Maryland, they're using the clinicians word, but we're not doing anything on our own to change that. And part of that is we have to change our mindset on how we treat people. I think another big one would be, this is going to be a really, really rough one for some people to grasp. How often do we give Narcan, 2 milligrams intranasally or more, or we get there and the police have slammed it, and people are screaming out, "What did you take? What did you take? What are you doing? What's your name?" Like everybody's like assaulting this guy verbally. Like, yo, hold up, man. Like this dude was just not breathing. He was 75% dead. He had a pulse. That's it. He wasn't breathing. Probably had a questionable airway. He was unconscious. And he's still most likely got cerebral hypoxia. So why are we yelling at this guy? And I'm really guilty of this one previously, previous jobs especially, because you start giving Narcan 8 times in 12 hours, it gets a little, it gets a little old. Again, this is a perception thing, and it goes back to the whole judgment concept we alluded to earlier, where like you're like, what did you take? It's like, well, now I'm thinking like, dude, we know what he took. He didn't take a benzo. If he did, it's still there, but he took an opiate or opioid.
Yeah.
Answer that question. The rest of your questions could probably be answered off his ID. He's probably got a license. If not, well, he'll wake up a little more, get a little bit of oxygen. Like, and I think that's another thing. Is like everybody's so quick to like wake people up who are overdosing. It's like, why don't we try oxygen? Let's treat hypoxia. Let's get some hypoxia, some breathe. A lot of times, if you start bagging somebody while you're trying to get an IV for Narcan, a little positive pressure with oxygenation does wonders. Maybe we don't need to give Narcan. Not giving Narcan can avoid a lot of problems, with the whole vomiting. I don't like vomiting in the back of a moving ambulance. It's not a good thing. But to me, and I think, again, this is where it gets even more controversial, probably to some people, I view somebody who's post-Narcan and who's just post-ictal. Somebody who's post-ictal, yeah, they were unconscious. The breathing status is messed up and probably had a questionable airway. Yeah, they had a lot more movement going on, but that's not voluntary movement. And they had a pulse. That's about it. You're pretty much 75% dead.
Right.
There's still some degree of cerebral hypoxia. That's why we have post-ictal, because of all these different, they're confused and all this
That's
stuff.
a good idea. That's a good idea.
And that's why I say, like, I think being post-Narcan is kind of similar. And, we sign up to help people. We don't get to say, and you can even put this into like today's world, we don't get to say, I don't want to treat you for this issue.
Mm-hmm.
When you get in emergency medicine, you sign up to treat people of all issues, all, socioeconomic classes. You don't get to say. So when you're treating somebody who has an addiction, we can think about, I kind of think like this. Yes, addiction is a disease. It's a disease of choice. However, they didn't choose to be addicted to the point where they're homeless. They didn't want that. That's not what they were looking for. It's kind of like, we look at like certain STDs, like look back syphilis 100 years ago, or I guess AIDS would be the next closest one. Yeah, people make a choice to get to where they're at with these diseases, but we treat AIDS patients now a lot better than we did 80 years ago.
Sure.
Sorry, not back in the 1980s, not 80 years ago. But back in the 1980s, there was always this big stigma, like, I don't want to catch that. I don't want this.
Yeah.
or wow, they did this activity to get this, and it's like it's their own issue. Now it's like,
Just isolated in rooms in hospitals. I think and actually, I think the person that gets some credit with that was like Princess Diana, because
yeah,
she actually was hugging these AIDS patients.
right. So like there was like a stigma. There's always again like syphilis and AIDS. I think are the biggest ones I can think of in modern medicine. Like there's these certain stigmas, and maybe even like I guess TB patients back in the day. You had your old school TB wards. I think the TB patients are kind of like your psych patients these days. Like we used to shove them away and just say hope for the best. And again, like I think syphilis and AIDS are kind of like that. We used to say hope for the best, and now it's addiction. Where this addiction, it's like, oh, it's not my problem. Hope for the best. It's like, how about we like try to take care of these people? I mean, social media's all over the place. I don't know if everybody remembers the show Jackass.
Yeah.
There's Brandon Novak was on there, and he was always on drugs. All those guys were on drugs. A lot of them came out just okay. Brandon Novak was probably the biggest junkie on the show. You can follow his progress on Facebook. Now he's a counselor getting people out of addiction. The guy just 37 years old, just got his license. He's a productive member of society that so many people would have discredited if they saw him on the side of a street overdosing.
That's the counselors in themselves. When we were talking about how EMS and maybe in emergency medicine, we're not the most empathetic, but pretty much every counselor I've ever seen has this lasting empathy.
Yeah, and that's again, it's hard because like so many of us, like I'm probably not the best one for addiction or psych, because I've pretty so far, knock on wood, obviously, I've done pretty good in the psychiatric department on my own.
Mm-hmm.
I don't have any addiction crises, thank God. Like I don't want those things. So maybe I don't have the best. I can't empathize for them
We're
because
just two dummies talking about our perspective.
right, like I've never been there. I've never lived that life. I've seen a lot of it.
Yeah.
It sucks. Like I don't want to live that life, but I've seen like what it can do. But then also it's like people are coming out of this, like, and they can be productive. It's just, maybe we aren't going to be the thing that changes them, but there might be one person who we like, all right, man, like, look, we just saved your life, you know, and like a lot of times, like, like back to the whole, like when we, Narcan someone, one of my things, I'm like, hey, man, here's what we did for you. Like, I explained the 75% dead concept. I'd like to do that one. I was like, you see this bag valve? I was holding this to keep you alive. I was like I was your lungs. Like, this is what we did to keep you alive, man. Like, it's a miracle you're here. It's not just, hey, we give you this drug. We shoved it in your veins and your nose, and now you're here because you did a stupid mistake. It's like, dude,
that's a surreal
like you're
statement
messed up on this.
You
like,
just gave someone.
Yeah, it's like sometimes I'll even like say, here, hold this. This was your lifeline. Like, it wasn't just me because I was bagging it. It could be anybody who was using this bag valve mask or this, this breathing device, or whatever I want to say to the person. This is what kept you alive. This is some oxygen.
But that's also a good point too. So what I want to bring up is continuity of care. So if you're like that and you do everything right, you're empathic, and then as soon as they get to the hospital and you get some other provider that just
so hard
does a 180 on them, you're just going to lose them, and even the person that was initially empathetic to them.
And that's a hard one. You do see it, but I think the ER has been doing good that a lot lately. But anyway, lately, it's like the last 5 years, easily. Like from the time I started in the county I work in, from the various other agencies I work for in the county to like where I'm now, it's like the nursing staff has changed mentally. And now maybe they haven't changed physically, but mentally they've changed. I think everybody, we got to this peak in the opioid crisis where everybody was like angry at everybody. It's like, all right, we can't just be angry. It's not good for anybody. And it's like, all right, we can get through. We got through that. We can get through this. It's like they are people. Like I said, we just talked about this earlier. Like I haven't really given Narcan in like forever. Not that I want to.
Talk about an epidemic too. Like look what happened. Look what changed with the opioid crisis. Yeah. It used to be those signs out front of the trooper barracks.
Yeah, like I don't know the last time they were updated either.
Yeah, but that used to be for vehicle collisions.
Right.
Now that's completely changed.
Yeah. And that's just another thing. It's like that whole epidemic. And I mean, I think we're still like in places dealing with it. I mean, I think you hear about a lot of it like out of Philadelphia and other like places, even within the state of Maryland. Like, it's still a thing. I think we're just kind of lucky where we're at because of our socioeconomic status. And I think like if you remove yourself from this, go somewhere else, you have to realize where you're working. It changes.
Mm-hmm. You get a higher percentage of certain calls dealing with certain things in a different area. Yeah.
if we go back to you talking about continuity of care, I think it goes back. I'll tie in with precept in a little bit. As a preceptor, I precept a decent amount of students. My goal is always to get these people to kind of like figure it out their own, but also kind of like throw things in that I like them to do. Like back to Narcan, I don't like nasal Narcan. I think it's horrible. I think it's, especially when people are doing like polypharmacy, it can really get you in a bad spot. Like if you give, IV Narcan, control their breathing, you're more likely to, not have them withdraw in the back of you or get combative. A lot of times somebody's combative, it's because they did coke or something with it.
But you know what? When you say that, that is the approach with Narcan. The Narcan is just like, oh, this person's unconscious. Oh, Narcan. Just
Right.
do it. Just do all the Narcan.
Right. And like I've had actually debates of this on calls in other jurisdictions where I was working part-time in a county that has a county-based fire department. I got to fight with a area supervisor about giving nasal Narcan. I was like, if you want to give nasal Narcan to the guy who is obviously overdosing but has a meth pipe right there, you're taking the call. I'm not taking this call.
Huh.
Like that's not like we have a polypharmacy issue, like especially talking about like meth or like something like that or crack. Like you take away that opioid downer concept. Now the all is a stimulant plus the adrenaline rush from being Narcan, which that was a thing in colleges was just overdosing, get the adrenaline rush was a thing for a couple years apparently. So you add that on top of that, like it creates a bad situation that becomes dangerous. You hear about like everybody used to be scared of giving Narcan because we get combative. Well, that's because people are mixing drugs. It wasn't just because you give too much Narcan.
I mean, also individual differences as well.
There are some individual differences, but usually, like a lot of times, that comes back to you give too much Narcan too fast and to a patient who probably should have had low dose Narcan. Like the point for this is one of the. There's sometimes where I get to disagree on the protocols. I think everybody disagrees on certain protocols. This is one where I think a lot of protocols in a lot of states get it right. The whole titrating to effective Narcan, because everybody's like, oh, it's also just this drug that has no side effects. It's like, no, malignant hypothermia is a real thing as well. And CHF is a real thing with fentanyl now,
Right. But also there's a misconception about how fast it works. And sometimes
yeah.
I think that's part of the issue is that someone will push it and they're like, oh, it's going to be like bringing up the dead.
Oh, yeah. You're like, I'll be back in a minute. It's like, no, nasal Narcan takes 5 to 10 minutes to work. They came back up in 2 minutes because you backed them. Mm-hmm. That's what did it. It's oxygen. Or, that's the reason you see it's not given an arrest anymore because what do we need to treat more? Hypoxia. You treat the opioid overdose doesn't do anything for them. At that point, it's a hypoxia thing.
Yeah.
And another thing I think back to this whole like opioid overdose concept is I think you still see it as the fact people in the field don't check glucose sometimes. I don't think it's as bad as it used to be at all. But you'll still see times people just don't check a glucose. And it's like sometimes diabetics kind of look at somebody who just did heroin.
Yeah.
They're clammy, they're pale, they're not breathing sometimes.
I remember coming up as a EMT and like every time a glucose wasn't done, it was like a guaranteed I'd be yelled at by a nurse.
Yeah. Honestly, I think that's what broke it. Everybody was like, why'd you do a glucose? It's like, oh my God, stop. Like even on chest pains, why'd you do a glucose? Oh my God, stop. And then
but that
I have a personal experience with it. I was like, okay, I should check the glucose on this patient because their sugar was 40 and now they don't have chest pain anymore because they have D10.
But even with continuity of care, there's always going to be someone that's going to say, why did you do that?
And I think this is like a whole.
Or why didn't you?
Yeah. I think talking about the Narcan is a good segue into this. Back to like the whole, we talked about MIs earlier. Because, Maryland pushed out the break it to me gently for arrest years ago.
I remember that.
About 5 years ago. Maybe Alcorta was still running the show. And, that was only for telling people telling providers how to tell family members their loved one died. I still think we can do a lot better on that because some people don't like to be blunt. I think it's something we could take this break it to me gently and expand it in the field is just be blunt with people. Don't sugarcoat it. Don't hide what's going on. Like, sir, you are having a heart attack. If it's a questionable MI where you're like, all right, this is a heart attack, but maybe their symptoms don't necessarily fit it. You tell them they have a heart attack, they're preparing for the worst at that point. Versus, I think the EKG is not really showing much, blah, 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 blah. Next thing they know, they're like, holy crap, why am I dead? I'd rather give me a little heads up on that one,
Yeah, really.
Well, back to like the overdoses, we keep talking about how to treat people. It's don't say, what are you taking, blah, blah, blah. It's like, hey man, look, I don't know what you took. I have a general idea. Here's what we had to do for you. You overdosed. Probably didn't mean to. If you did, we can discuss that. We can get you avenues for that kind of help too. You still need to get help for your addiction, but I'm not mad. I didn't do this. I did this myself. I'm here to help you. I'm here to help people. That's my goal. But There's no reason to scream at them.
Right. It used to be every overdose call I would get, or even treating an overdose as a nurse, like I always try to tell them, like, I'm not here to get you in trouble. I
Yeah.
just want to make sure you're
And that
okay.
goes back to, I think, definitely with EMS as the bridge between law enforcement and the ER, because we do wear the same uniforms as cops.
Yeah.
Especially with the advent of EMS wearing vest, good, bad, or indifferent. There's multiple ways to look at that, but every day we look more like law enforcement. And so many people have, like this authority attitude with that just carries over to ER sometimes, I think. Maybe that you don't mean it to, but the patient thinks it does.
I do feel really cool wearing a vest.
We can talk about that. I feel really hot.
That's true too. Midsummer with a bulletproof vest on, not so comfortable.
Yeah, it's not fun. I think the issue with humanizing the calls is, we're going to start wrapping up a little bit, is the thing about why don't we want to humanize? It's because we were trying to avoid our own vulnerable mentalities. PTSD is a big thing. I was listening to a paramedic before I came here talk about how there's a certain county around here that in the past 5 years had 8 people with 15 plus years on the job kill themselves.
Yeah, that's
all this stuff does take a toll on you, and it's sometimes people want to think that we can avoid it by humanizing the job. I was always told growing up as an EM when I was a little EMT, in high school I was an EMT. It's just don't get too attached to people, man. Just keep on. There'll be more. There'll be more. There'll be more. And it's so I'm not talking to people in the back of the ambulance, and it's all right. And then I had my first kid die. Holy crap.
That's a rough one. That's a rough one for a lot of providers.
And I think that's where everybody gets their first major holy crap. It's when they see a dead child.
If there's guaranteed to see someone cry, it's those events, and they are rough.
Yeah, if you're with a provider who's not crying when they're doing CPR on a child, either they've done it way too many times, or B, they're not a good person.
Yeah.
I've seen some really hardcore, crusty medics do CPR on a child and cry, and I was wow, I never thought I'd see this person cry.
Yeah.
One of my favorite providers that I looked up to, who is now a nurse, the day I saw him cry, I was this is another learning moment for me. He's a really phenomenal provider. He's a goofy guy, he makes fun of his patients, but they love it. Some patients like that, Some patients want to hear music. What's wrong with playing music for the patients? Some patients want to be kidded around with. They want to be joked with. People want to see that you're a person. And so often we don't do that. We have this guard up around us. Yeah. And we don't want to let them into hey, we listen to music.
You're a person with a medical background. And there's things that you can think of outside of the protocols, outside of policy, that you can do to make a patient much more comfortable. The music one,
music's a big thing. I try to use music a lot for anxiety attacks. Maybe don't need to go to the hospital. Again, that's another time for another day. But music is a weird little thing that so many people enjoy. It's non-destructive. It's not harmful to you. But everybody has a favorite type of music. Music's been around since humans have been around. It's been around for a reason. It calms us.
So there's people that still listen to Danzig to calm down.
Hey man, I'll listen to some Misfits. I got a punk rock shirt on right now.
I just have a shirt full of baby drool all over.
I have friends their go-to when they're mad is Slipknot. And I'm all right, I'll get down to that if I'm a little angry. They're wow, I'm calm. Some people want to listen to Jack Johnson. Some people want to listen to jazz.
Whatever works. Whatever.
It's one of those weird things. It's if you can say, hey, how about we put some music on for the ride to the hospital? We calm them down. It's it's weird. It's not a protocol. But is that treating somebody? Probably. But again, it opens you up because now the person's well, what's this person listen to? It forces you to make a human connection that we're afraid to make.
And you relate to somebody.
Right. We're afraid to relate and make these connections because we're afraid to get attached when something bad happens to the patient.
Which is rough, too. Don't let that be mistaken.
Oh, no, that is fair. It's all rough. I have a freaking flyer who I loved her to death. She used to fight us all the time, not physically, but verbally argue with us about going to the hospital. Look, I'm not coming back here and putting a breathing tube in your throat. And she get kicks out of being talked to like that. Is that kind of harassment? Maybe, but some people like that. But that's knowing who your patients are. The day she died, I found out I literally cried. I was I loved her. She was great. She was part of there's certain freaking flyers who are still around. I'm people get annoyed by them. Why are you getting annoyed by this person? They have a legitimate issue that needs treated. They're not really burdening you. If anything, they're giving you a 25, 30-minute break while you give some D10 or D50.
Yeah.
And then what do you got to do? You got to make a connection with the family. You start talking to them. You know, when they do die, it sucks.
And then maybe that's just a matter of perspective after that. Like
Yeah.
you have the perspective, like you were able to treat someone and you did the best of your ability and you cared.
Right.
And you did this job for how many years and you still care at the end of it.
Right. Like I said, I think when I look at like, you know, when I first started this, I looked up to the old crusty paramedics who had that I don't give a frick attitude. You know, it's like, all right, they're the ones I want to be like. Now it's like I look up to medics and like I want to be like the guy who, and like really I guess it's like now there's like doctors I guess I look up to at this point who are like they give phenomenal patient care, but when somebody in my family dies, I want them to be the one to tell us to me.
Mm-hmm.
When I need somebody who is in my family who needs cardioverted, I want them to explain it.
And some of that comes with rapport.
Yeah, patient rapport is like I think this kind of is like a big whole discussion of patient rapport and like just using good patient rapport.
Yeah, no, that's a big thing. So thinking back to medic school and trying to wrap this up here too, and nursing school, there is this big emphasis to try to teach empathy.
You know what? There was, and it just didn't get across, did it?
No, I just don't. It's a strange thing to have on a PowerPoint slide.
It is. Like I don't think you can teach that by book. You have to find the people who are good at it, and like say like, what do you do? You know, like if I was going to do this like a podcast again, I'd turn like an 8-hour podcast, and the people I was just like referencing, I'd be like, let's bring these people in.
Yeah,
They're
let's
awesome.
bring them in.
Let's have a huge round table. Let's get some beer. Let's get it going. You know.
I am working on getting like a mental health person on the next podcast.
Yeah, I mean, like I said, like it's you know, there's like so much that we have to cram into our jobs. I guess that it is hard to humanize what we do. But yeah, we are treating people. We're not treating numbers. I think that really does get lost.
No, that's
and like people, you know, there's a lot of people who like are scared to help people advance in EMS. Who you know, like, well, they're people too.
right.
Your coworkers are people. You know, you have to go home. Your family's people. Everybody, we're all just people. You know, if I get back in, I don't want to be talked to like shit. It's not gonna be a good experience. You know,
Mm-hmm.
I'm sure you wouldn't either. I mean, it's gonna say a lot for A, that provider in the future, and B, the employer, and then the medical system they work in. You know, if you have a bad experience one place with one provider, like I can think of places where I've been in my little experiences that I've written on like the firefighting aspect of it and dealt with providers. I'm like, wow, this provider's a jerk. They suck. This must be what everybody's like.
Mm-hmm.
And if, you know, I know it's not right, but that's what the perception I have still. It's like this system sucks.
And I know these things, and even so I like to say that, you know, you should bring up people. When you bring people up and you make them better, they in turn are going to make you better.
It's grooming.
Yeah. But there are days, and I'm guilty of it too, like you just get so beat up and
I think it's worse
your
for you
attitude
guys.
dampers down a little bit. But that's a matter of perspective and just trying to keep yourself honest.
I think it's a good time to do this. I mean, I know I wanted to kind of stray from the COVID stuff a lot, but I think it's a good time to have this conversation because you are seeing people, and if you're not seeing them now, you're going to see them. By the time this podcast comes up, maybe you've hit your peak, but you're going to see it. And it's scary. Like when you're looking at somebody who's rolling down the hallway, coming in from another hospital, like 45 miles away because the hospital's overflowing and they're like your age, they're intubated, they're sedated just enough to like not care, but they're still sedated enough to where like they can lock eyes to you and say like they have the help me look. It's like this is real, man.
Yeah,
you know, and again, like
very surreal.
Humanizing and like this is gonna be hard in a situation like this where it's just gonna be a beatdown, but at the same time, it's like at what point do you stop caring about people and you just don't care, you know?
And hopefully it just never gets to that point. We keep trying to help each other out, trying to help the community out.
I think that's something is you got to help each other out.
Yeah.
You know, if you see somebody who's not like treating patients right, it's like, yeah, man, like you're great at what you do, but it's like, why are you being an asshole? Just be blunt. It's like, yeah, just being blunt. It's like if I'll see like, if I like show up late and I'm seeing somebody else, hey man, why? Like I'll say in front of the patient, like maybe it might damage that person in front of the patient, and that's kind of rude. But it's like, why are you being an asshole? Like, what'd they do?
Yeah.
Like we're here to help the patient. Or it's like, hey man, look, I know you're fighting with the cops. Maybe I would too. I don't know. I don't know your situation. I don't know what they did, but I'm not the cops, man. I'm gonna make you feel better. Like that's what I'm here to do is help you out.
That's all I care about.
I'll get you away from the cops. It's like nothing against the police, but sometimes just their presence stresses situations out. So sometimes just removing that can help. The quicker sometimes you can mitigate that part of it, you know, might help you out.
About health literacy for police officers as well.
We could do that.
Yeah. All
Maybe
right.
not we, you.
Well,
degrees on the wall.
we'll see. No, don't talk about my degrees on the wall. It's all just paper. Well, Cody, I want to thank you. This was an awesome podcast. You were an excellent speaker.
I did what I could.
I did not even expect this. I've worked with you before. I'm just kidding. Well, this was the 4th episode of the Status Dramaticus podcast. You can email us at statusdramaticusrnems@gmail.com. You can check out the podcast on Podbean, and you can check it out on YouTube. We're always looking for more listeners, of course. Build it up, get it out there. But also looking for people to present things that they find really that they're passionate about. Cody found something he was very passionate about, and this is an excellent discussion. Now I have more questions, but we can't go for another 8 hours, I don't think.
Oh. My work might not like that.
So, this has been the Status Dramaticus podcast. Thank you all for listening. Have a good night.
Good night.